Hello, everybody. My name is Nitish Padwar. I am a cardiac electrophysiologist. I work in San Francisco at the University of California, San Francisco. I'm going to be talking to you about atrial fibrillation, which is one of the growing epidemics in cardiology, internal medicine also. My talk today is mainly going to be divided into 4 different parts, which the first one is incidence and prevalence of disease burden. Then we talk about drug therapy, then stroke prevention, and then finally catheter ablation therapy. So the first slide here is taken from a publication from Circulation, which shows that atrial fibrillation is growing at an epidemic proportion in this is taken from United States, but it's it's growing at an epidemic proportion, which I think it's worldwide. And you can see the growth in men overall and in women. So it's everyone. And this is up to 2000. But when you go and look at it and look at the projected numbers, atrial fibrillation is about 5 to 6 million. And if it keeps growing at the rate it was growing, in 2030, we would have about 10, 11 million people with atrial fibrillation. And by 2050, you would have about 16 million patients with atrial fibrillation. So it's definitely an epidemic that we have to be able to manage as time goes along. And this is true everywhere in the world. This is data from Framingham. And again, this is showing the same kind of thing, that this is a disease mainly of the elderly. As you get older, the prevalence of atrial fibrillation gets much more. This slide shows you different forms of heart rhythm problems that lead to hospitalization. And as you can see, atrial fibrillation alone accounts for 34% of hospitalizations for arrhythmias as a primary cause. So clearly, there is no question that in our field, this is the number one rhythm disorder that we need to be aware of and need to be targeting.
Nitish, if I can pause you for 1 second. Start. Thank you.
Great. We can start?
Yes.
Okay. So in this slide, what we are trying to show is that atrial fibrillation doesn't exist alone. Atrial fibrillation exists usually in the presence of other heart diseases. The way I tell my patients as well as my trainees is that you have to think of atrial fibrillation like a systemic disease. It's not a localized rhythm disorder that patients have. So this slide shows you that 65% of the patients who have atrial fibrillation have some form of heart disease associated with it, which means could have hypertension, could have obesity, could have diabetes. So atrial fibrillation is associated with that. So in other words, if you are managing a patient with atrial fibrillation, you don't want to just specifically manage atrial fibrillation. You have to look at the patient as a whole. You have to look at managing diabetes, managing obesity, managing hypertension. If you control those things better, then you have a better chance of being able to control atrial fibrillation. Now, 1/3 of the patients do present with what we call lone atrial fibrillation. In other words, in these patients, atrial fibrillation is not associated with heart disease. So these are the patients where if you specifically just target therapy for atrial fibrillation, you can sort of cure it or treat it more successfully. So this slide shows you what are the problems that can be associated with atrial fibrillation. So the number one is obviously symptoms. So the patients will feel their heart beating fast. They'll have symptoms of palpitations. They'll feel discomfort. They have chest discomfort. They can have rapid rates. They can have dizziness. They can, feel like they're going to pass out. Their quality of life is bad. The this is the most common presentation. But then there is since this is a disease of the elderly, there are patients who are old who are not aware of that the heart starts beating fast. So these patients will not come complaining of, dizziness or palpitations or things like that. But what can happen is if their heart keeps beating fast, so if their ventricular rate is fast because of atrial fibrillation, they can present with what we call tachycardia-induced cardiomyopathy, which means their heart function goes down. So they start having symptoms of heart failure. Now, it has been shown that atrial fibrillation is associated with increase in cardiac mortality. It is also associated with increase in stroke risk. Now, that is a very important thing that I'm going to address in the next section, which is something that you need to take home from this talk, that significant amount of strokes, especially in the elderly, are associated with atrial fibrillation. So overall, it turns out that it's a big burden to the healthcare system. Burden in the sense of patients presenting with symptoms and coming to the hospital. Burden in the sense of the sequelae of atrial fibrillation, which includes stroke, and managing those patients, managing strokes, managing the quality of life of patients after they have strokes. So that is why we have to, be paid a lot of attention to this disease and how we manage it. Now, if you look at how we classify atrial fibrillation, there are different ways of doing it. And one simple way of classifying it is dividing it into three parts. One is called paroxysmal, one is persistent, and then third one would be permanent. So paroxysmal atrial fibrillation would be patients who go into atrial fibrillation and then it stops by itself. The episodes can last few minutes, few hours, or it can even last a couple of days. But eventually, the patients get out of atrial fibrillation by themselves. Persistent atrial fibrillation is usually atrial fibrillation that comes on and does not go away by itself. And usually it lasts, we call it persistent if it lasts for about a week or so. You usually require electrical cardioversion or pharmacological cardioversion to put these patients back into sinus rhythm. And then finally, the last one would be permanent, where despite attempting cardioversion, these patients stay in atrial fibrillation. So no matter what you try, you cannot get them out of atrial fibrillation. If you look at the duration, the patients who have paroxysmal will have had atrial fibrillation for the least amount of time. As time goes on, patients can go from paroxysmal to persistent to permanent. So the earlier you catch this disease and earlier you try to modify it, the better chances you have of preventing paroxysmal from going into persistent. How do we manage patients with atrial fibrillation? So the management strategy is based on what is shown in these red bars over here. So the number one thing that we have to do, because the ventricle is beating fast, the atrial fibrillation is fast rate in the atrium, which is making the lower chamber of the heart, which is the ventricle, beat very fast. So most of the symptoms are because of that. So you got to give them rate control, which is drugs to slow the ventricular rate. So these would be drugs like AV nodal blockers. The second thing that we would want to do is to try to get them out of atrial fibrillation. So this strategy is called rhythm control strategy. And then the third thing, which I think is the most important thing in atrial fibrillation, is reducing the risk of stroke in these patients. And to do these things, we have different things available. We have simple things like cardioversion, we have antiarrhythmic drugs, we have procedures called catheter ablation, we have drugs that thin the blood to prevent these patients from getting stroke. And then finally, we can put implantable devices in these patients, which can help manage some of these patients with atrial fibrillation. So I'm just going to start the second part, which is drug therapy. If you want to look at drug therapy for atrial fibrillation, the best place to look for that would be the atrial fibrillation guidelines, which you can get from PubMed. And these atrial fibrillation guidelines were published by consensus statement from ACC, ASA, European Heart Rhythm Society, ESC. The last guidelines were from 2011. They get updated every now and then. But this is the gist of how we treat these patients. So this is a list of different drugs that you can use for rhythm control in these patients, which means keeping them in normal rhythm, keeping them out of circulation. Now, the drug therapy is based on 4 different kinds of diseases that the patients might have. If the patients have no heart disease, so as I showed you earlier, about 1/3 of the patients who present with atrial fibrillation don't have any heart disease. So in these patients, you can use almost any of these drugs. Usually we start off with drugs like dronedarone or Maltac, flecainide, propafenone, and sotalol. So you could use any of these as first-line drugs. These are easier to use. You don't need to put the patient in the hospital for these drugs. And then if they fail any of these drugs, then you can go into one of the other ones, or you can go to second-line therapy, which you would be using drugs like amiodarone, dofetilide. Now, amiodarone might be a drug which is available throughout the world. So any part of the world, I'm sure at your institution, you should also have amiodarone available. And again, flecainide and propafenone are older drugs, so they are generic drugs. There might also be some form of them available. So the second line therapy would be, if you fail one of these, then the second line therapy is either go to these drugs, or you can do a procedure in these patients, which is called catheter ablation. And I'll talk more about the procedure when we address that. Now, the second set of patients would be patients who have atrial fibrillation associated with hypertension, which is very common. It's the most common cause of atrial fibrillation as people get older. So in hypertension, you have to do an echocardiogram on these patients to look at the thickness in the ventricle. If the ventricle is very thick, if they have substantial left ventricular hypertrophy, then unfortunately, most of these other drugs are not indicated as per the guidelines. So as per the guidelines, the only drug that is safe would be a drug called amiodarone. If the patient does not have significant LVH, then again, you could use any of the drugs that were used in the first group of patients, which is dronedarone, flecainide, propafenone, sotalol. And then again, if you fail first round of drugs, then you can go to second round of drugs, or you can offer catheter ablation to these patients. Basically, the gist of these guidelines are that you have to try drug therapy as a first-line therapy. And then if they fail drug therapy, then the second line can be catheter ablation or another round of drug therapy. The third category of patients will be patients who have atrial fibrillation that is associated with heart disease, with coronary artery disease. So these patients have already had a heart attack, or they have known coronary artery disease. So in these patients, unfortunately, you can't use class 1C drugs. And class 1C drugs are flecainide and propafenone. So the only ones available then would be dronedarone or Maltac, sotalol, or dofetilide. And then if you cannot take any of these, then again you could go to amiodarone or catheter ablation. And then finally, the last category would be patients who have heart failure associated with atrial fibrillation. In patients who have heart failure associated with atrial fibrillation, only 2 drugs can be used, and that is either amiodarone or dofetilide. Dofetilide is also known as Ticocin, as the brand drug in the United States. And I don't know how much of that is available in the other parts of the world. But it's a very effective drug to maintain sinus rhythm in patients who have heart failure and persistent atrial fibrillation. Again, if you fail these drugs, then you don't have a second-line drug therapy available in these patients. And the only option is to do a procedure called catheter ablation. So this is a useful guide for anybody who is taking care of patients with atrial fibrillation. Now, when these patients present to the hospital with atrial fibrillation and rapid ventricular rates, and they have symptoms, significant symptoms associated with that, or they have low ejection fraction and they have heart failure associated with that, we try to cardiovert them and put them back into normal rhythm. So to do that, we can either electrically cardiovert them or we can try drug therapy. So the drug therapy that is available for cardioversion includes intravenous drugs like ibutylide. You can use intravenous procainamide, which is a very old drug, which I'm sure is available in most parts of the world. You can use intravenous flecainide or propafenone, which we don't have available here in the US, but I think it's available in Europe for sure. I don't know if it's available in your institution. You can use sotalol, which is again a very old drug. You can use oral dofetilide, which is sort of the same class as ibutylide, but it's an oral drug. And then in some patients who have idiopathic atrial fibrillation, which means without heart disease, in these patients, we sometimes use what we call pill in the pocket approach. So we tell these patients, instead of taking these drugs all the time, these are patients who probably have atrial fibrillation maybe 3 to 4 times a year. So instead of taking a drug all the time, we tell them to keep these drugs with them and only take a higher dose of flecainide or propafenone at the time that they have atrial fibrillation. That usually leads to conversion into normal rhythm within 2 to 3 hours. Whenever we use any rhythm control strategy, we have to make sure that the patients are taking rate control, which means they are on some form of AV nodal blockers to prevent the ventricular rate from being fast. And the reason for that is many of these rhythm control drugs, if they're given alone, can convert atrial fibrillation into atrial flutter. And if that happens, the ventricular rate will actually speed up. Because the atrial flutter is a slower rhythm, so it can conduct much faster to the ventricles. So if the patient is not taking AV nodal blocking drugs and you give a rhythm control drug to these patients, you can actually make them worse. So we always teach our trainees that anytime you're using a rhythm control drug in atrial fibrillation, you've got to make sure the patient is on AV nodal blocking drug. So what are some of the new drugs? These are some of the drugs that are in the pipeline. Some of them have been developed. So dronidrone is a drug that is similar to amiodarone, except it doesn't have the side effects that amiodarone has, which are associated with the iodine thing. And that would include effect on thyroid function, on long-term effect on the lungs, as well as on the liver. So it's supposed to not have many of these side effects. However, we've been using it for a long time. The efficacy of this drug has not really panned out. And it might be that amiodarone being associated with the iodine moiety helps it to be more effective. There are other atrial specific drugs. So these are drugs only affect the atrial channels, and they are also in the pipeline. Varnacalant has already been approved for acute cardioversion, and there are other gap junction enhancements in the works to make them more effective for atrial fibrillation. Now, how do we assess the success of drug therapy? The problem is that atrial fibrillation is, as I told you, is more of a systemic disease. So it's not a localized rhythm control problem. And so it's very hard to cure it or to treat it completely eradicate it. So in some patients, the success of atrial fibrillation therapy is actually decreasing the burden of atrial fibrillation. It's not completely eliminating it, but to decrease the burden. So it could be you decrease the time to first recurrence, which means the patient was having episodes 3 to 4 times a month. Now with this drug therapy, they maybe have episodes maybe once in 2 to 3 months. So that would be called a success, even though they still have atrial fibrillation. So that's a common thing that I see many times when I treat these patients and send them back to their primary care providers, and they have an episode of atrial fibrillation. They call me back and say, the therapy failed. I tell them the therapy did not fail. It has decreased the incidence and it has decreased the burden of atrial fibrillation patient. And that is probably the best thing we can do. You can decrease the duration of episode. Some patients might be having episodes that are lasting as long as a few hours, or even a day or two. And now they have episodes that only last for a few seconds or sometimes few minutes. So that might be a form of success for these patients. And then,
Question.
yes, go ahead.
Most of these drugs you just mentioned, we don't have in the hospital. At times we use digoxin.
Very important to know the success of atrial fibrillation is you have to have a reliable way to monitor the burden of atrial fibrillation, which means you have to be able to monitor the amount of atrial fibrillation that the patients have. And that you have to figure out what are the resources available to you. Obviously, in more advanced countries like US, we have implantable devices that we can implant in patients, which can record atrial fibrillation and let us know. Nowadays, there is a push of recording these things through things like the Apple Watch. There are things that can be put on the phones, which can record these things, so which is easier for people. It depends on how much of this technology is available. I sometimes use very simple things with patients, which is blood pressure measuring instruments. So almost everybody, you can, I'm sure they can buy or have access to things to measure the blood pressure. And any machine that measures blood pressure also measures the heart rate. So that is one simple thing that I use with my patients, to do that once a day so they can know when they go out of rhythm and when they are in atrial fibrillation. But you have to have some reliable way to measure that. That is the only way you can know what the burden of atrial fibrillation is. So now I'm going to focus on a very important part of this talk. And if you want to just take home one message from this whole talk, would be about stroke prevention. Because this is the worst thing that can happen to patients with atrial fibrillation. And not only is it bad for the patient in terms of quality of life and their survival, but it is also a significant healthcare burden for any healthcare system. So I think focusing on stroke prevention is the most important thing in patients with atrial fibrillation. So this slide just shows you the percentage of strokes that are associated with atrial fibrillation. So as you can see, as patients get older than 80 years old, about 20 to 30% of the strokes are caused by atrial fibrillation. It's a significant cause of strokes as patients get old. The risk factors for, so what you have to do is define the risk factors for stroke in these patients. So whenever I see a patient with atrial fibrillation, the first thing I do is look at what is the risk of this patient for having stroke. And the risk would include previous history of stroke, rheumatic heart disease, which if you still have it in your country, that is the most important. These are the most important risk factors for future stroke. If they have any of these, then there is no question the patients have to be on lifelong anticoagulation. The other risk factors include age more than 75, hypertension, diabetes, heart failure, ejection fraction less than 35%, hyperthyroidism, hypertrophic cardiomyopathy. Hyperthyroidism is an important thing. Whenever somebody is diagnosed with atrial fibrillation for the first time, you always got to rule out causes of atrial fibrillation that are reversible, and hyperthyroidism is one of them. So we always check thyroid function testing in patients to make sure that patients are not hyperthyroid, and that is not what is leading to atrial fibrillation. In fact, sometimes if they have hyperthyroidism, unless you treat that, you will not be able to control the rate, even in patients with atrial fibrillation. So this is a very important slide in terms of showing you the efficacy of anticoagulant therapy in preventing strokes in these patients. So this is a slide that included all these PAC trials. And what it is showing you is that if you give placebo versus warfarin, Warfarin is an age-old anticoagulant drug that is available in every part of the world. If you give warfarin to these patients, you can decrease the stroke incidence from 4.5% annually to about 1% annually. This is a significant improvement, and it shows that the increase in bleeding is not that high. This is provided you keep warfarin in the therapeutic range, which is an INR between 2 and 3. Now, what are the newer forms of stroke prevention therapies available in these patients? So obviously there are procedures which I'm sure will be limited in your part of the world, but there are other drugs that are available which are become better, which are not only better, I mean, they are better than warfarin. Again, it depends on availability of these drugs. These newer drugs are called novel anticoagulants or direct oral anticoagulants, and they have recently been available since 2010-11 and have been shown to be very effective in preventing strokes as good as warfarin. So the first one that was available was a drug called dabigatran, which is known as Pradaxa over here, and I think that is the only form that is available. And this was a trial published in New England Journal that showed that there were 2 doses used. One was 110 milligrams and one was 150. The 150 milligram of dabigatran was superior to warfarin in preventing strokes when these patients were followed about 2.5 years. The other drug that is approved is a drug called rivaroxaban, which is again an oral anticoagulant. And it again showed that it was equivalent to warfarin in this trial, which is called the Rocket AF trial, in preventing strokes in the long run. And then the third drug that was approved is the drug called apixaban, which was done. This is data from a trial called the Aristotle trial, where this drug showed actually improvement in mortality and stroke prevention as compared to warfarin over the follow-up period. So the question always becomes that these drugs are costly. You know, they are brand drugs as opposed to warfarin, which is a generic drug. However, there have been a lot of cost-effective analysis, and they have shown that if you use these drugs, they are better than warfarin. This particular one was done using dabigatran because that has been around the longest. But now we have cost-effectiveness done with all of these direct oral anticoagulants or NOACs, and they have shown that they are all better. The reason is that in warfarin, the levels are not very stable. And you have a lot of interaction. You have to change the dose back and forth. The patients have to have a blood test done. With these drugs, you don't need to do anything. You just give a dose of the drug based on the kidney function in most of the patients. And so in the long run, when you follow these patients, they are more, they give you more effective anticoagulation with less bleeding. Definitely less intracranial bleeding, which is one of the things that worry patients as well as doctors when they prescribe oral anticoagulants. So if you look at cost effectiveness, these drugs happen to be more cost effective than warfarin, even though they are more expensive to start off. Now, if the patients fail drug therapy or cannot take drug therapy because of bleeding risk, then you have to look at other ways to prevent stroke in these patients. And one of the ways to prevent stroke in these patients is to go after a structure in the left atrium, which is called the left atrial appendage. What this slide is showing you is that most of the clots that cause strokes in patients with atrial fibrillation, more than 90% of the time, these clots come from a structure called the left atrial appendage, which is a pouch-like structure in the left atrium, which is the left upper chamber of the heart. So if that is the case, and these patients cannot get drug therapy, or as it turns out, there were some trials done, if they want an alternative to drug therapy. Suppose you have a patient who is 50 years old, doesn't want to take an oral anticoagulant therapy for the rest of their life. Then you can devise some procedures to exclude the left atrial appendage to prevent stroke in these patients. So this slide shows you a list of different kinds of devices that you can use in these patients to prevent strokes. So if you look at this animation and the picture in the middle, this is the left atrium. In the left atrium, there is a structure called the left atrial appendage. This is the left atrial appendage. So either you can occlude the left atrial appendage by putting in a device called the Watchman device. There is another device called the amulet device, which is shown over here, or Coherex device, which are all devices that can be lodged in this structure, and then they can lead to closure by tissue overgrowth on top of this. Or you can use another method, which we've devised here, which is called the lariat method, where you go in and through a catheter-based method, you can tie off the neck of the appendage. So I'll just show you a little bit through pictures what we mean by doing these procedures. So the first one that was devised is called the Watchman device, which includes putting this kind of device in the left upper chamber, in the left atrial appendage. This is a TE picture of the left atrial appendage. Usually the left atrial appendage would have been empty here. Now you see it's been filled up with the device and the tissue has been sealed off. So this has been closed, and that will lead to prevention of stroke. This is a CT scan on the same patient, where you can see that that device has been lodged in the left atrial appendage. It has been endothelialized. So that left atrial appendage has been closed off by the device. The landmark study that was done with Watchman device is called the PROTECT AF trial, which was a randomized study comparing Watchman device to Warfarin in patients who are eligible for anticoagulant therapy. This is the other technique of excluding the left atrial appendage. This is something that we started here at UCSF, and now it has been used all over mostly in most parts of the US as well as Europe. And it is shown to be an effective therapy. What this is doing is, it is making something that the surgeons do. The surgeons can tie off the left atrial appendage, but they have to open the chest to do that. Here, what we do is through catheter-based methods, we can tie off the left atrial appendage by doing an endocardial and epicardial approach. As you can see here, you're injecting dye, the left atrial appendage is open. By the time you do this procedure, over here, the left atrial appendage has been closed. Now, when you inject dye, nothing is going into the left atrial appendage. This does require some expertise in doing it, because you have to be very good in doing dry epicardial puncture in these patients. But it is just showing you that through catheter-based methods, we can do this procedure, which was earlier only possible to be done by a surgeon by cutting open the chest. And again, this is an example of a patient who has a TEE done. So this is the left atrial appendage on the TEE. And after tying off, you can see that the left atrial appendage is now closed. Nothing is going down over here. So this is data showing closure rates of the left atrial appendage using different techniques. So this is a surgical technique, which is called the Atri clip, where they put a clip on top of the appendage. The closure rate is about 95% or more. With the Watchman, the closure rate was 86% in the PROTECT trial, but I think in the subsequent trial, their closure rate is also more than 90%. And the lariat has not been done in that many patients, but the first paper that was published with it showed a closure rate of about 96%. However, if you look at numbers, probably you're going to find more patients with Watchman than with Atri clip than with the lariat technique. This is the data from PROTECT AF, which showed that there is not only equivalency, but actually using the Watchman device causes better mortality and morbidity as compared to Warfarin. So this was a randomized study. And so this is a real landmark study showing that device therapy can prevent stroke in these patients. This is sort of a slide that has been made to not compare against each other, but sort of project it like that. So these are data available from the NOACs NOACs were the dabigatran, rivaroxaban, and apixaban, comparing those to warfarin. And this is data comparing Watchman to warfarin. So this just shows you that Watchman to warfarin gives you a better efficacy in terms of mortality protection and reduction in strokes as compared to the oral anticoagulant drugs. And then finally, the last part of my talk is going to be focused on what we call catheter ablation therapy in patients with atrial fibrillation. So in ablation therapy, catheter ablation means taking a catheter from the groin, going into the heart, which is the right or the left upper chamber of the heart, and you can burn the tissue through that catheter and permanently destroy it. It can be used for 3 different techniques which can affect patients with atrial fibrillation. So the first one is you can use catheter ablation to cause AV nodal blocking. So as you guys were describing to me, you have patients who come in with atrial fibrillation and rapid ventricular rates, and you have difficulty controlling their rates. And if you don't have any intravenous drugs available, these patients and their oral therapy either is not optimal or they cannot take optimal doses because of blood pressure, they can keep coming into the hospital with this therapy, with atrial fibrillation, which can then keep making them go into heart failure. So one technique would be to take a catheter and destroy the AV node. So no matter how much atrial fibrillation the patient has, the ventricular rate is always controlled. You would have to put a pacemaker in the ventricle after that. But this is one technique that we use in older patients where we have difficulty giving drug therapy to control the rate. In fact, this was the first procedure that was ever done as a catheter ablation in any human being in the whole world. And that was done here at UCSF in 1980. So this is a very simple technique. It's a very simple procedure to do. The second procedure that we can do to destroy tissue would be taking patients who we think have tachycardia-induced tachycardia. So in other words, in these patients, there is some other form of tachycardia, supraventricular tachycardia, that then pushes them into atrial fibrillation. So if you control the first supraventricular tachycardia, or you can ablate it, then you can prevent that from causing atrial fibrillation. So these two are relatively simple to do, easy to do. The final ablation would be an ablation just to cure atrial fibrillation. And I'll show you what that means, what that involves, and what the data is for that. So as I told you, the first catheter ablation that was ever done in a human being was done for patient with atrial fibrillation and was done to destroy the AV node. And this is the paper from that, Dr. Scheinman, who did that, and he still works with us at UCSF. This was published in 1982, and it was done in 1981. What they did was, this is a cartoon of the heart. So this is showing you that they've taken a catheter from the groin through the femoral vein, gone through the IVC into this area called the AV node. AV node is the conducting tissue between the atrium and the ventricle, and you go and destroy the structure by burning it. So now, no matter how fast the atrium beats, the ventricle cannot beat fast. And most of the symptoms happen because this is beating fast. So then after that, you have to put a pacemaker. So this is an EKG of the patient, atrial fibrillation with rapid, irregular rates. After the procedure, there is a pacemaker. The patient is still in atrial fibrillation, but the pacemaker is controlling the ventricular rate, which is very well controlled. So this procedure has been done for a long time. We have data with this procedure that it leads to clinical improvement of symptoms. It leads to better hemodynamics. These patients stay out of heart failure. And there is data to show that if you pace both the ventricles as opposed to just one ventricle, that is better than just pacing one ventricle. So this is something that we use as second-line therapy in older patients where we are not going to go for rhythm control. We are just interested in rate control, but the drug therapy is not able to control them because they are not able to take optimal doses of drugs because they can't tolerate it or their blood pressure doesn't allow you to give higher doses of these drugs. The second part was what we call tachycardia-induced tachycardia. which means there is some other supraventricular tachycardia that causes atrial fibrillation. So here we could have what we call AV node reentry tachycardia, AV reentry tachycardia, or atrial flutter, which can then cause atrial fibrillation. So if we treat the initiating tachycardia, we ablate the initiating tachycardia, then we can prevent it from causing atrial fibrillation. So this is an example. So this is an example of a patient who on the top part has a very rapid and regular rhythm. See, the rhythm is very regular. So this is supraventricular tachycardia. Then that slowly degenerates into atrial fibrillation. So this is fast but irregular. So in this patient, we were able to get rid of the supraventricular tachycardia by doing simple catheter ablation and prevent the atrial fibrillation. And finally, the last part is what we call ablation therapy to cure atrial fibrillation. So the concept for this was actually given to us by the surgeons. The surgeons were the first ones to do some kind of a ablative procedure for atrial fibrillation. And this procedure was pioneered by James Cox in St. Louis, and so it's called the Cox procedure or the Mays procedure. And what their goal was that the atrial fibrillation they thought was because of multiple re-entry happening in the upper chambers of the heart, both the right and left atrium. And their goal was to destroy the tissue in both the chambers so that the sinus rhythm follows a simple maze or a simple path and to conduct, and the other re-entries don't happen. So this is a cartoon of the maze procedure. So what they do is, most of it is done in the left atrium. There is in the posterior, they isolate the posterior left atrium. So which means the 4 pulmonary veins are isolated. You then remove the left atrial appendage because that can cause atrial fibrillation. It can also cause strokes with atrial fibrillation. So this is all cut and sew. So they open the heart, you use sternotomy, you cut the tissue and oversew it to do these things. And then you can connect it to the some barrier. So in this case, you connect it to the appendage, base of the appendage, you connect it to the isthmus, mitral isthmus over here. You also did lines in the right upper chamber of the heart, and they would draw a line from the SVC to the IVC. Draw a line means they would cut and sew over there and also remove the appendage on that side. So this is the cut and sew maze. Now, nobody wants to be exposed to sternotomy to do this kind of procedure. So now the surgeons have evolved minimally invasive surgical techniques to do this. What is the data? This procedure is the oldest one. So we have more than 10-year data with this procedure. And the patients who got the original Cox-Maze procedure, if you look at the 10-year data, it's very good. The success rate of this procedure is very good. However, as I told you, now nobody wants to do sternotomy as a primary atrial fibrillation ablation procedure. So the surgeons have developed techniques where they can do it from side holes. So they just make holes on the 2 sides of the chest and go from there, as opposed to doing a sternotomy. And this is a technique, they use a clip like this to go over the veins and do ablation procedure. Based on this, the catheter ablation procedure that are done by electrophysiologists were developed. And what we realized, the reason the surgeons were very successful was they were isolating the posterior left atrium, which I showed you here. And what they were doing is they were really isolating the 4 pulmonary veins. So these pulmonary veins have muscle sleeves on top of them. And that is what is caused firing and causing atrial fibrillation in most of these patients. And so that is what led to the development of catheter ablation techniques, which are done by us through the groin, just putting holes in the veins. And the idea is that these muscle sleeves from the pulmonary veins fire fast and cause atrial fibrillation. And so if you go and electrically isolate these veins, you can prevent atrial fibrillation in most of these patients. So this was the seminal paper that came out of Michel Hassaguer's lab in France in 1998. And this is the idea behind doing this procedure. This is sort of a PA view of the heart. This is the left atrium. This is the SVC. This is the IVC. And you can see muscle sleeves around these veins. And so the goal is to electrically isolate these muscle sleeves. So this cartoon shows you how this is done. You sort of make a puncture between the right and left atrium. You take a circular map catheter that you put around the veins, and then you sort of burn around this to electrically isolate the veins. Okay? This is just a simplistic version of how this is done. This technique has evolved through different iterations, and I'm not going to go through all of them. This is just more for technical purposes how we do this technique. But it's good enough to show that by doing this technique, you can achieve rhythm control in most of the patients with atrial fibrillation. So then the question becomes, who is an ideal candidate for this kind of procedure? And the ideal candidate for this kind of procedure would be somebody who has symptoms because of atrial fibrillation. That is the key word that you have to remember. The patients have to be symptomatic. If you see patients who have atrial fibrillation but they are not even aware of it, doing this procedure is not very useful for them. So they have to be symptomatic and they have to have failed one line of drug therapy. That is what the guidelines said. So you take these patients and you try them on one set of drugs. If they don't respond to that, then you can offer this kind of therapy to them. What we do use in this therapy is it does require some amount of equipment to do this procedure. You need an intracardiac ultrasound. You need a CT scan done on these patients. Because the CT scan is important, it gives you the anatomy of the left atrium, which is different in different patients, the location of the pulmonary veins. It also gives you the location of the esophagus. We have to be very careful. The esophagus is very close to the left atrium. If we are very aggressive, we can cause damage in the esophagus with this procedure. So you need CT scan, you need an ultrasound during the procedure, and then you need a three-dimensional mapping system. And so basically you go and draw, these red dots are all burned, which are done around the veins to electrically isolate them. And this slide just shows you an example of one of the patients. This is a CT scan of the patient, which is merged with the three-dimensional map of the patient. And this shows that this is the left upper vein, the left lower vein, right upper vein, the right lower vein. This is showing you that the patient is in atrial fibrillation. When ablation is being done here, it suddenly terminates and goes into sinus. So this is sort of the reason why this procedure is done, because by isolating these veins, you can lead to maintenance of sinus rhythm in these patients. When we start doing this procedure for everybody, we realize everybody doesn't have the same response rate. And one of the reasons for that is that atrial fibrillation might not be the same in everybody. So this is an MRI on 3 different patients with atrial fibrillation. In one patient, the MRI is normal. In the other patient, the MRI shows scar. This green thing is scar. And in this other patient, third patient, it shows severe scar. So the more scarring you see in the left upper chamber, the less chances that anything will be successful in keeping them in sinus rhythm, including drug therapy or catheter ablation. So this is important work that was done from Utah, where they showed that doing an MRI on these patients can allow you to select patients for the catheter ablation therapy. So in other words, a patient like this who has minimal scar will do very well with the procedure, whereas a patient who has severe scar is not going to do as well with procedure or even with drug therapy. So you might elect to just treat them with rate control therapy. This is the data. This slide shows you a data of all the trials, randomized trials comparing catheter ablation to drug therapy. And most of the follow-up is about 1 year, but you can see it is very impressive. The data is, you cannot have any better data than this. Look at the success rate with ablation, 66% versus drug therapy, 16%, 63% versus 13%, 90% versus 44%. So it's very clear that the catheter ablation therapy is much more effective than drug therapy. You just have to have the expertise of somebody to do it and the equipment to do this kind of procedure. The success is also based on what form of atrial fibrillation the patients have. So patients who have paroxysmal atrial fibrillation will respond the best. Patients who have persistent will have lesser success rate, so 84% to 74%, and the patient who have long-lasting atrial fibrillation will have even less success rate. Finally, any procedure is going to be associated with complication. So this slide gives you a list of complications associated with the procedures, which is usually of the order of 1 to 2%. And again, it's very important to have an informed decision with these patients in terms of the risk and benefits of doing the procedure. And this is a surgical procedure where we now do minimally invasive surgical ablation procedure. So that is a slide showing you about that. And then there are other techniques available to do these procedures, which is using balloon-based therapy, which again, I'm not going to go in the details. So what do we have to look forward in the future in terms of data coming back for patients with atrial fibrillation? For future, I think one important trial which is finished enrolling is this trial called the Cabana trial. This was done through Mayo Clinic by Doug Packer, and it was NIH-sponsored trial. And this trial is going to answer a very important question. This was a randomized study comparing drug therapy to catheter ablation in patients with atrial fibrillation. So this is going to tell us whether catheter ablation therapy is really important for total mortality. If it is, then it could offer this as a first-line therapy as opposed to right now where it is a second-line therapy. And in this trial, they're looking at everything, not just total mortality, but also secondary endpoint of stroke, heart attack risk, and serious bleeding. So it's a useful trial. The follow-up will finish in another year or so, and you should look at data coming out from this trial in most of the meetings where they can give you some data about what will happen. So this will allow us to manage patients much better. In terms of maintaining sinus rhythm, the other trials based on catheter-based therapy are now involving different forms of techniques for catheter ablation. And we are trying to do catheter-based procedure, which is similar to the Cox procedure. And so another trial that we are participating, which is also going to be useful, which we think in catheter ablation will be something to look forward to, is what we call the AMAZE trial, which again, you can go to their websites and look at it, both for Cabana and AMAZE. It is a randomized study of techniques of ablation, where one set of ablation is just catheter ablation. The second one is catheter ablation plus ligation of the left atrial appendage, to see if that will be more effective in maintaining sinus rhythm as well as stroke prevention in these patients. And then there are different other device therapies that are being looked at to remove the left atrial appendage in patients who cannot take drug therapy or don't want to take anticoagulant therapy. To me, I think these are the more important things, because the real big issue with atrial fibrillation is stroke prevention. So these are all things that are something to look forward to in the future. So just to conclude, I gave you a rough idea about what the prevalence and incidence of atrial fibrillation is, what kind of drug therapy you can use in patients with atrial fibrillation, how do you prevent strokes in these patients, and why is it important to prevent stroke in these patients. And finally, if patients are not able to maintain sinus rhythm with drug therapy, what are the different techniques of ablative therapy available in these patients to maintain sinus rhythm? Thank you.